Welcome to the CAA 2022 webinar series. Today's webinar is how a dedicated dressing can improve patient safety and ultimately patient outcomes with speaker Matty McDonnell, supported by 3M. Thanks for joining us and please enjoy.
Welcome to the Council of Ambulance Authorities webinar series. I'm David Waters, the Chief Executive of the CAA, and I will be your host today. Today's webinar is proudly supported by 3M. Today, we will discuss a small but mighty innovation believed to significantly improve patient safety and ultimately patient outcomes. National and international recommendations for many years have advocated for the prompt removal of peripheral intravenous cannulas that are inserted in emergency situations. The goal of the project is to redesign the 1633 dressing to include the word emergency to prompt clinical staff to remove the device. Stick around and hear about the development, the implementation, and the results of the project. Our speaker today is Matty McDonnell. He is the clinical nurse consultant for the Vascular Access Surveillance Team Infection Management Services at the Princess Alexandra Hospital. He has a Masters of Advanced Practice in Nursing with a focus on critical care and a postgrad qual in clinical redesign. Matty, with over 10 years experience as an intensive care nurse and formerly employed as the National Clinical Educator, specialising in ventilation, intra-aortic balloon pump and vascular access, is dedicated to positive patient outcomes and lifelong learning. Thank you for joining us today, Matty, and please enjoy the webinar. Thank you.
Hi. My name's Matty McDonnell. I'm the Vascular Access Clinical Nurse Consultant at the Princess Alexandra Hospital in Brisbane. Today, I'm delighted to be sharing with you a quality initiative project that started at the PA and has gone global. Our goal was to look at emergency situation devices, how they're inserted, and their removal rates. I'm going to share with you now my screen so we can go on this journey together. So this was a partnership between PA and 3M. We were looking at how a dedicated dressing can improve patient safety and optimise patient outcomes. Our learning objectives for today are to look at the role of the 1633E dressing in emergency situation devices, describe the scope of the Queensland Ambulance Service project, and outline those results here at the PA, how by implementing the 1633E dressing, we saw a reduction in our hospital-associated bloodstream infections, or BSIs. So before we get there, it's important to understand why we embarked on this journey. The relevance of the data is newer and some of the data is older. So most recently, as I'm sure you're all aware, the Australian Commission on Safety and Quality, released the PIVC Clinical Care Standard, and Quality Statement 10 talks to the removal or prompt removal of emergency situation devices within a short time period, so ideally within 24 hours. That statement has also been backed up for many years now by the INS, or the Infusion Nurse Society guidelines, which also talks to the prompt removal of emergency devices within a 24 to 48 hour window. And finally, the Australian Commission for Standard 3, which is the prevention and control of healthcare associated infections, has required the prompt removal of emergency situation devices with 24 hours for some time now. The relevance here is quite pertinent because what we don't know about emergency situation devices, such as those that are put in the community by our emergency or our first responders, such as the Queensland Ambulance Service, is the state to which those devices are put in. Specifically, we don't have an understanding around how the patient was found, where they were found, and the emergency need or the necessity to put that cannula in. So it could be roadside, it could be a multi-trauma, it could be a patient that was found in a home environment that isn't particularly clean, and the device was inserted quickly to ensure that therapy could be commenced as soon as possible. When we look at devices that are put in an emergency situation, what we're specifically referring to is not emergency as in the emergency department, but devices that are put in where the maintenance of the aseptic technique may not be held. So it may be that they couldn't uphold aseptic technique because of the necessity to get that device in as soon as possible, or it could be that a practitioner, for example, is inserting a device in a very difficult person or patient in a code, for example, and the clinician knows that they've, for example, repalpated the skin after they've used their chlorhexidine alcohol to prep the skin. So that's what we're referring to when we talk to emergency situation devices. There is often some confusion, specifically, as I mentioned, around the emergency department itself. So it's important when we're considering prompt removal of emergency situation devices that we are looking to what's happening with asepsis. Has it been maintained? Hasn't it been maintained? And certainly here at the PA hospital, we put a big emphasis on our clinicians being accountable for their practice. So if they know that they've not been able to maintain asepsis because we are digital, we require that the clinician who inserted the device to tick yes to emergency situation, and then that generates an order within EMR or IEMR, our digital platform through Cerner, that device then needs to be replaced within 24 hours. So the question still comes back to, if the device isn't inserted within your facility or our facility, we actually don't know when and how that device was put in. So that's why we always go to, if the device wasn't inserted in our facility here at the Princess Alexandra Hospital, then we remove that device within 24 hours. There's always extenuating circumstances. Of course, the patient journey needs to be considered, and we need to optimise their outcome. So if it's not safe to remove that device within 24 hours because, for example, perhaps they're on particular medications, so maybe they're on some vasopressors and we've not been able to get a central line in, etc., we won't just remove the device for the sake of removing the device. We need to make sure that it's safe for the patient. The other category that we often see where we're not able to remove it exactly at the 24-hour mark is our patients who have undergone, for example, our code stroke patients who may have undergone some clot busting therapies, and we need to make sure that all of their coagulation profile is back to normal before we look to remove those devices. So what does all that look like here at PA, and how did we get to looking at our having a robust QI process around what did our pre-data look like, what did we implement, and then what does our post-data look like? So here on the screen, you'll see, as I mentioned, we are a digital hospital. So we have the luxury of being able to run reports each day. So my service, myself and 2 clinical nurses, we're able to run a report through the digital system that pulls every patient that has a dynamic group or has a indication of a line. So we call them dynamic groups. And so we run that report for all lines. So I'm going to talk today specifically about cannulas, but we're able to see from that report all devices that are dwelling in our patients, providing that dynamic group exists. And we then provide a surveillance service, patient education, staff education, etc., based on that list. So on the left of your screen, you'll see that's just our raw data. So just telling us, I've just filtered out one section as a screen grab to show you, but just all the different devices, when they were inserted, who they were inserted by, etc., and was it an emergency situation? Importantly, just to note that this data has been de-identified, so there's no patient data here, but I would, however, emphasize that this PowerPoint is not to be shared outside of this meeting that we're having today. On the right of the screen, you'll see that once myself and my team have filtered through the data, we use a color-coded system just to highlight the types of patients that we're seeing, just so we can reduce the amount of, or the busyness of the page that we print to go and see our patients. So our color-coded system, just for your reference, our green coloring is our devices that are overdue. So in this hospital, in alignment with the standard 3 documents, we dwell our devices for 4 days. So any devices that are green are overdue. So they're either 5 days or older. Our yellow devices there are our external facility. so they've come to us from another hospital. Our pink, or that sort of fuchsia colour, are devices that have been listed as emergency situation. So they're devices that we need to go and review and provide some education to the teams regarding prompt removal. And our red colouring is our ambulance devices, which also require that prompt removal when safe to do so. So reciting those devices. So prior to this project, we have always in this facility used the standard Tegaderm 1633 dressing. We at the Princess Alexandra Hospital, and in fact across Metro South, for probably close to 8 years, have used standardized cannulation kits. So there's lots of evidence around standardizing your practice. So in our cannulation kits, we have everything that's required for successful cannulation other than the cannula itself and the tourniquet. So the Tegaderm dressing has always come in our cannulation kits, and it still does. But for the sake of this pilot, we had to reach out and discuss with both 3M and the Queensland Ambulance Service what dressings were being used. And in fact, they were also using, they being the Queensland Ambulance Service, or QAS, were also using the Tegaderm dressing. And then there was some backwards and forwards between all bodies involved, so the PA, 3M, and the QAS, regarding what the proposed dressing would look like. And importantly, we wanted to make sure that the labelling of the dressing was reflected of what's actually happening with our patient. So we wanted to make sure, of course, that the dressing didn't just say QAS, or that it was really obvious that the device has been put in an emergency situation. And the poster that you're now seeing, there's actually been lots of revision of this poster. So when we first embarked on this journey, you'll see within that little circle there, the first image that was put together was actually using a hand model. So it didn't really sing to the staff that the device may not have been put in under ideal circumstances. So through work with myself and 3M, we were able to come up with the image, which is on the background now. So that close-up is still there, but we've now moved to this image that, and of course, all of our devices that come from QAS, not everyone's obviously a roadside trauma, so they may not have blood, etc., all over their hands, but we wanted to emphasize that we don't know the background of how these devices were put in, or how the patients were found, and whether or not asepsis was maintained. So this is the current poster that's available and supplied by 3M. The other change that was made with this specific iteration of the poster is we now say remove, recite, and replace the PIVC within 24 hours. So there was some confusion despite lots of education and in-services by both the VAST service as well as 3M themselves with all of our facilities, all of our wards that use this or use the device and receive patients via the QAS. But there were some situations where the dressing themselves were being changed and the cannula itself wasn't being changed. So that was just an education gap that needed to be fixed. And also you'll see just in brackets at the top there that our goal moving forward, and we haven't got to this yet, was to start with our ambulance services, removing those using this dressing for ambulance services, and then implementing the dressing then within our own facility for our rapid responses or our MET calls or RRTs, whatever terminology you're using within your facility. So we wanted to really honour what those three references I spoke to earlier had mentioned. So it's not exclusively our ambulance services, which is why our dressing that we developed with 3M says an emergency rather than QAS, for example. We had the luxury of working with 3M, and we were able to start to look at our data collection, both pre and post removal rate. So you'll see early on in the piece, and this data, so this was data that we sent to 3M, and they were fortunate enough to have a black belt in Lean Six Sigma who was able to analyze our data, giving us our upper control limits or UCL and our lower control limits, LCL. and then what that data looked like in between. So what's important to note is we only really started collecting data, the data was only really collected at the beginning of 2018. And what we knew before we embarked on this journey was that our removal rates for devices that were inserted in an emergency situation were less than 40%, which is reflective on this graph, and sometimes quite low, down to sort of 20% and less. But that's really the journey that we've gone on with this dressing, because you can only imagine a patient that comes in with multiple lines, both from your emergency services into the emergency department, and it's quite difficult to ascertain exactly where each device was inserted. So what I mean by that is when the QAS is using a standard tegaderm dressing, they're on the left again, and when and our own emergency department are using the tegaderm dressing, it was quite difficult to map out exactly who was using what device, where that device was inserted based just on the dressings alone. So that's sort of the crux of why we started on this journey, so we could really map out where the devices were inserted and then action those. So coming back to our Lean Six Sigma graph, you can see over the trend here from 2018 and prior to collecting data, as I mentioned, our removal rates were quite low. And then as soon as we started to put an emphasis on the need to remove devices within 24 hours, the rate started to increase. What you can see here as we start to trend into 2019 is some of the challenges that we faced within the PA hospital and the relationships that we'd built with the Queensland Ambulance Service while working on this QI. So the rollout actually was due to go live in 2018, except there was a hold up with several different factors. So making sure we had enough supply of the dressing, and of course looking at what our usage would be. Bearing in mind that the initial rollout, and here in Metro South, for us, the rollout was aimed at just the Queensland Ambulance Service. So still in Metro South, the 5 hospitals that make up Metro South, we don't use the dedicated 1633E or the emergency dressing for our inpatient areas. It's still only used by the Queensland Ambulance Service. So we needed to wait for that education to happen, both from the Queensland Ambulance Service in partnership with 3M. We obviously needed to wait for stock to be available for the Queensland Ambulance Service, and then of course for that stock to be rolled out. So we were hoping sort of towards the end of 2018 that the rollout would occur, and it really didn't start to occur until sort of mid to end of 2019. You can see we're starting to get some more spikes across the top of that graph. And what we learned when we reached out to our colleagues at QAS is, much like our inpatient areas, is we always have stashes, or like clinicians, clinicians that work in the healthcare setting always have stashes of equipment and stock, etc., in some obscure places. So some of the rollout was really dependent on giving the QAS enough lead time to wind their stock down. Of course, we don't want to waste money for the sake of a project. Undergoing training, implementing the 1633E dressing for that trial, and then having staff trained up on the need to just use that dressing, and for that dressing to be available in each and every one of the QAS vehicles themselves, as well as in their backpacks and all those sorts of things that are used. So we saw as the dressing actually became available for everybody to utilize, that we started to get our peaks in the removal rate. So looking at quite high there, removal rates sort of over 80%, which is fantastic for us as well. So just for the sake of this project and this presentation, we did stop collecting data. COVID hit. It was too challenging for my team and I to continue to collect the data. But I did retrospectively do an audit of charts for all of October for 2020, and we could see that the removal rate at that point was at 85%. So really celebrating success in relation to how quickly those devices were removed. and ongoing. I had a quick little look just the other day, actually, just probably maybe just less than 100 charts I reviewed, and our removal rates are actually now well over 90%. And there's lots of factors that have influenced that. Of course, we now have gross education around the hospital in relation to what the dressing means, the posters. Every sort of 3 months or so, I ask 3M to come and do mass education in each of our inpatient areas, just kind of reminding staff of the need to remove the device within that 24-hour window, and also what the impact is, which I want to talk to you about now for our next steps moving forward. So, as I mentioned, we will continue to reevaluate our removal rates. We are sitting quite high in our removal rates, and we did have a little bit of a sort of a drop, I suppose, if you will, throughout the COVID period. And of course, that's related to several other factors, such as an influx of staff, both new staff as well as agency staff who may not be familiar with the devices, etc. So really looking at reevaluating the removal rates. So probably looking at collecting data for a couple of months to ensure that our removal rates are still quite high. In relation to our bloodstream infections, so just taking a step back, the reason why this is so important, as in the removal within 24 hours, we're not able to guarantee that asepsis has been maintained. Specifically, from my perspective and working with our scientists, our infection control scientists, and some of our colleagues over at UQ, is what we know from an infectious diseases perspective, and what the Health Commission knows, is that the rate, both morbidity and mortality rates of patients who are diagnosed with a Staph aureus bacteremia are quite high. So all-cause mortality in these patients is very high. And we know lots about Staph aureus in relation to that organism. So we know that it loves warm, moist environments. We know that it's a skin bug. So we know that every person has Staph aureus over their skin. We know that it's a really resilient bug. And we know lots of little interesting facts about staph. So we know that it loves hair follicles. We know that it loves summer because it's obviously warmer. And we see, anecdotally, we see that our staph infections are actually higher in the warmer months. So thinking about Queensland, warm skin, moist environments, hair follicles, and then coupled all of that with emergency situation where we may not have time to say clip the hair. Okay, so using some clippers to remove as much of the hair as possible. That coupled with perhaps the inability to prep the skin because it's an emergency situation, and then how the patient was found, so either their home environment, roadside, etc. All of those factors come into why we have that evidence around the need to remove devices within 24 hours. So for us here at PA, I've been doing a lot of work with one of the academics from UQ, and we are looking at our bloodstream infection rates and a link to our emergency situation devices, both before the implementation of the 1633E dressing, as well as our removal rates post-implementation, and where we've seen the removal rates peak. And I'm very pleased to share with you that our removal rates, with the increase in removal rates, our bloodstream infections associated with those devices has reduced significantly. So it's fantastic to see that hard work really does pay off. And in fact, we're just in the process of writing that research paper up. So we will publish that, hopefully, either late this year in 2022 or early 2023. And it's fascinating to see also that this simple or dedicated, simple, yes, but dedicated dressing, just highlighting the importance of removing the cannula within 24 hours, has actually gone global now. So I've met with 3M America, for example, looking at why we implemented this dressing, what did our data show, and where we will go with the dressing, which is really important. And finally, as I've touched on, our goal moving forward will be to have the dressing available in the hospital. So it won't just be our emergency services or QAS that'll have access to the dressing, that we will, in fact, have the dressing available on our emergency trolleys, for example, And where we know that asepsis has been breached, we will use this dressing as a quite a simple flag, and that was sort of always the goal, that it's a visual indicator acknowledging that that specific device has been put in a situation where we can't guarantee that asepsis has been maintained, and that the importance is to remove that device within 24 hours. So we'll move from there, obviously, to our RRTs or rapid responses, where we know that a device is put in with those breaches in asepsis. So that comes to the conclusion of my presentation. I wanted to keep it nice and brief, just so we had the opportunity to answer any questions, which I'd be delighted to hear from you. So thank you for your time. I hope that this has been insightful for you, and I look forward to answering all your questions. So have a delightful day. Thanks again.
Thanks, Matty. Great presentation, and a wonderful piece of research that has a massive impact on patient outcomes and patient care. Thank you for sharing that with us this afternoon. A big thank you to 3M for sponsoring this webinar, but also for supporting Matty in his very important piece of research. Great to see so many people from 3M online today. Great to see you, team. Also great to see so many of our infection control practitioners from across ambulance services in Australia and New Zealand online also. I think you have to agree that the 1633E, E for emergency, I'm assuming, product is a great innovation, and certainly will have a massive impact on patient outcomes going forward. Be interesting to see which other ambulance services are keen to adopt this dressing and work with their hospitals to, I guess, get feedback on their bloodstream infection rates. And we're all really keen to understand that. We know that across ambulance services, all services are improving their hand washing techniques, their aseptic techniques. So we're doing a lot, as much as we can, but I think this is also an important adjunct to those innovations to reduce patient-acquired infections in our practice. So again, thank you all for joining. Great to see so many of you online today. We'll keep the chat open. Please get your questions into the chat function. Much for the presentation, Matty. We really appreciate it. And it was actually really nice because I know this issue around peripheral lines has been front of mind for so many of us for such a long time. Yes. In coming up with a system to address it in such a way that improves patient safety and patient outcomes is really important. So, and a big thanks to 3M for supporting this, the webinar, and supporting you. So some of the questions, I'll go through a couple of the questions we received from the participants. The first one was, have you seen a noticeable change in the rate of phlebitis since the program was introduced?
Specifically to those devices, categorically, I'd have to say yes. And that's because from my presentation, like, our removal rates have significantly increased. So I think that sort of last section of data I captured for a month, our removal rates were sort of around that 85%. So because we're getting the devices out in a timely fashion, which of course is in line with what both the national and international recommendations are, we're significantly seeing less phlebitis and less infections, both, bloodstream infections as well as sort of that local level phlebitis.
That's great. One of the questions that kind of flows on from that is one of the participants wanted to know if the dressings were dated in order to give an indication as to how long it had been. I'm guessing the concept here is it's an ambulance inserted cannula, it's coming out, whatever.
Yes, yeah, you're correct there, David. So So at the moment for our health service, we the way that the project was rolled out was that QAS exclusively have the dressings. We don't have them in our organisation. That is certainly the plan down the track for when we have, because we've got to remember that when I talk about the recommendations, it's referring to devices where we've not been able to maintain asepsis. So regardless of if that's in a community setting with, our ambulance colleagues, whether or not that's in hospital and it's a code a situation or emergency, irrespective. But at this stage of the rollout or of the project, it purely sits with QAS. So for us, if we see that dressing on a patient, that dedicated dressing, then we know it must be removed, within 24 hours. So there are, of course, always extenuating circumstances. If we've got a patient that's, for example, undergone lysis, and we're not wanting to remove that until their coagulation profile comes back to normal, then we can delay the removal. But the whole point is of the dressing, as you said, by 3M, that 1633E, is that it's a visual prompt to let us know that that specific cannula has been put in an emergency situation, and so it needs to be removed. So I suppose in a nutshell, they're not dated. They don't really need a date because we know when the patients come in. If we've clocked over to the next day, then that cannula needs to be removed ASAP or as soon as safe to do so.
Excellent. How have you found paramedic uptake in regards to utilising these dressings? I can't imagine any reason not to do it.
Yeah, that was actually one of the lessons learned from the project when I kind of looked at all of the data, some of the work we were doing at the back end with 3M and then long term for myself, and I'm at sort of the pointy end of having this particular project and the outcomes written up with an academic at UQ. What we didn't foresee, I suppose in a way we should have with all clinicians, is we're all very good at hoarding whatever, dressings, equipment, etc. So we had a rollout date for the dressing, and we thought from the front end, so we as in PA had done our due diligence, 3M had done what they needed to do. We'd obviously been in consultation with QAS, but what we didn't foresee is twofold. So one, we didn't have complete overview over, and I suppose it's very unpredictable, the number of dressings of the old dressing that were being used across the ambulance service, but also where some of those dressings were being ferreted away. They weren't just in, bag X where we thought all the dressings were. They were also in other areas. So we saw a little bit of a mismatch of uptake. And once we fed that back to colleagues at the QAS, we then saw, oh no, yes, we're still running stock down. Yes, we have found dressings in places we didn't know there were. But once we sort of abolished the old dressings and it was, no, all we've got is the emergency dressings, then we saw a lot more rolling through the door. And you'll see that on that graph that I gave you from 3M. You saw that, there was a delay from when we released the dressings to the removal rates peaking. And I can talk to some of that data for, exactly what I've just discussed, that it sort of was a bit of a stock on hold issue.
Not surprising, knowing paramedics are well known for storing just in case everything.
And I think most of the hospitals are as well.
It was really lots of the attendees were keen to access the dressing, so it kind of resonated. I had a couple of questions around access, I guess. Cost in relation to, is it a similar price or same price as the equivalent dressing without emergency written on it, and availability in regards to the supply chain issues of the world at the moment.
So cost, I couldn't actually tell you. I don't know because I don't work at at that back end with procurement. But I know our health service very well, and I dare say that we wouldn't have rolled over to something that was significantly more expensive. Full stop. So the short answer is I don't actually know the cost differential between what we were using and what we're currently using. I think also where cost gets a little bit challenging, and I imagine that the 3M team will be able to answer this a little bit more clearly, but I know from a Queensland Health perspective, we go through all of our tenders, so we have our, SOA, etc. And because we can forecast our volume of stock, for all of Queensland Health, we often are at, say, a different price point to where a private facility is that's maybe only using, 10 a week kind of thing. So 3M could probably give you a better cost analysis, and I'm sure they'd be very happy to. What I would say on cost, however, is what I can talk to from a Bloodstream perspective, and we certainly saw a lot of Staph aureus bacteremias with emergency type cannulas, whether they be ambulance or not, is we know from the Australian Commission that all Staph aureus bacteremias that are preventable is considered a hospital-acquired complication. So we get a financial penalty of $12,500 per SAB or Staph aureus bacteremia. Okay. And we know also from the Australian Health Commission that per bloodstream infection, it costs an organisation, so an institution like a hospital, approximately $35,000 per bloodstream infection. So even if the dressings were going up, say, $1, and your infection risks went from whatever they were to zero, you're already saving several thousands of dollars, if not hundreds of thousands of dollars per annum. And we are certainly seeing that our Staph aureus rate, specifically around cannulas that are inserted in emergency situations, have dropped off. I suppose talks volumes. In terms of availability, with what's happening with stock shortages, with the current climate, at the back end of COVID, we at no point have had issues with stock. So I certainly haven't heard that QAS has got issues with stock. We're still seeing emergency dressings come through our ED doors. There's been no communication to me either via procurement, or I sort of represent the whole of this hospital and the vascular access portfolio across Metro South, and there's been no communication to myself. So I can't foresee that there is stock issues. But again, I suppose for absolute clarity, that would be a question for 3M around stock holdings and where the manufacturing happens.
That's great insight. Thank you. Obviously, in the ambulance sector, we're having an increased focus on aseptic techniques. So we're trying to reduce that incidence in the first instance. Secondly, yes. A reduction in the frequency or the number of cannulations. I think we have a bit of a track record for over-cannulating.
Yes.
But thirdly, we're moving more and more to peripheral cannulation kits, so a package, as opposed to pulling together lots of individual components. And obviously, it's unlikely that this particular dressing will appear in those packs at this stage. So I think I'm not looking for an answer here. I think I'm just flagging that there is, you implement processes to try and improve patient care, patient outcomes. Sometimes you have to rethink those in order to get the, best bang for your buck in relation to what we've just discussed.
Yes.
So hopefully in the not too distant future, if organizations move to standardized cannulation kits, 3M dressing appears within them.
Well, I know, so we, as PA and then Metro South, so we actually have and have done for a number of years now, we have standardized cannulation packs. And in my tenure in the vascular access CNC position, I've actually changed what we have in those cannulation packs, and we now have a new pack provider or assembly point as well. So what I can talk to through what you've just said is that, first of all, the research will always support standardization. So I'm absolutely very supportive of standardized kits. You are able to have whatever components you like in those kits. So we in hospital have our 1633 dressing. So that's the standard cannula dressing without emergency written on it.
Yep.
And I've actually reconfigured those packs. So depending on who you go with for your pack provider, you will actually be able to package all of the ambulance kits with the emergency dressing in them. That won't be an issue. So that hopefully won't change practice there. And yeah, like I obviously the work that you're doing on that aseptic front, certainly we would, from an organisational perspective, we would continue to do what we do, which is to remove devices that come from QAS within 24 hours anyway. And the reason we would do that is because, as I've mentioned, that is supported by both the Standard 3 component of the Australian Health Commission, but also when you look at the INS guidelines, etc., it says that any device that's put in by emergency services should be removed within 24 hours. And the reason for that is because we may know that the patient's saying MVA, but we don't know the circumstances around how the device was inserted. So it's easier just to remove it when safe to do so and pop another one in where we can guarantee that, that asepsis has been maintained.
Absolutely. And it's just as likely that it's a collapsed patient on a bathroom floor.
Exactly.
Exactly. Yeah. So awesome. It's been great talking to you, Matty.
Yes,
that's all my questions. We've really enjoyed it. But we'll stay in touch and really keen to see the rest of your research.
Wonderful. Thanks for your time, David. And if there are any more questions that pop up, please feel free to give me a bell.
I will. Thank you so much. You take care now.
You too.
Cheers.
See you. Bye.
Thank you for attending How a Dedicated Dressing Can Improve Patient Safety and Ultimately Patient Outcomes with speaker Matthew McDonnell, supported by 3M. Join us for our next webinar on Tuesday, the 25th of October at 11 a.m. Australian Eastern Daylight Time for the topic of cardiac arrest, supported by Philips. View all of our upcoming webinars by visiting www.caa.net.au/webinars. And in the meantime, be sure to follow us on social media, Twitter at CAA Australasia, Facebook and LinkedIn, the Council of Ambulance Authorities Australasia. Thanks for joining us, and we'll see you next time.